afternoon, everyone. My name is Tamara Ruggiero with the American Kidney Fund. I'm Chief Communications and Marketing Officer, and I want to welcome you all to this afternoon's topic, which is Advancements in Medical Therapies for Diabetic Kidney Disease, also known as DKD. Our goal today is to share about the highly effective medications that can slow the progression of diabetic kidney disease, and also to talk about the low utilization for these therapies among patients. So right now, it's my pleasure to introduce our three distinguished panelists. First, Dr. Amy Model. Dr. Model is an associate professor of medicine at the University of North Carolina, Chapel Hill in the Division of Nephrology and Hypertension. Her clinical interests include multidisciplinary care, education, and health equity for patients with diabetic kidney disease, glomerular and genetic kidney diseases. She focuses on collaboration with primary care providers and subspecialists to deliver patient-centered, guideline-driven care, expanding access to medications with cardiorenal benefits for patients with CKD, as well as medical weight loss therapies. Welcome, Dr. Model.
Thank you. It's wonderful to be here.
Thank you. Next, Dr. Suzanne Nicholas. Dr. Nicholas is a tenured professor of medicine at the David Gavin School of Medicine at UCLA in the Nephrology, General Internal Medicine, and Endocrinology, Diabetes, and Metabolism divisions. She is NIH funded, and she studies diabetic kidney disease mechanisms, novel therapies, biomarkers, and CKD disparities. She is president of Women in Nephrology. She's vice chair of the UC Council on Research Policy, chair of the UCLA Nephrology Racial Health Equity Committee, and an NIH study section. She serves on the ASN Healthcare Justice and Kidney Health Initiative APOL1 steering committees and the American Heart Association Council on the Kidney and Cardiovascular Disease. She received the AKF Medical Advisory Board Distinguished Service Award and the Minority Access Incorporated National Role Model Faculty Researcher Award. She has over 120 original publications on diabetic kidney disease, hypertension, and health disparities, and she is on the editorial board for the American Journal of Nephrology and the American Journal of Kidney Diseases. Welcome, Dr. Nicholas.
Thank you very much. It's a pleasure for me to be part of the kickoff of Kidney Action Week.
Wonderful. And finally, we are so grateful to have Dr. Patrick G. join us today. Dr. G was diagnosed with diabetes in 2003 and stage 3B chronic kidney disease 10 years later in 2013. And he is here to tell us about his experience with diabetes and kidney disease. He has been both a peritoneal dialysis and a hemodialysis patient, and he received a kidney transplant in 2017. He's made changes to his daily life that have improved his overall health. Dr. G received his Doctor of Philosophy in Justice, Law, and Criminology in 2012, and currently he serves as the founder and chief executive hope dealer of iAdvocate Incorporated, a nonprofit faith-based health and wellness organization. He's also an ordained minister at Mountain Movers Ministry. And lastly, he is a patient representative for the Diabetic Kidney Disease Collaborative Task Force, which has allowed him to advocate for those living with chronic kidney disease. Welcome, Dr. G.
Thank you so much. It's an honor and pleasure for me to be here today.
So before we get started, I want to encourage everyone joining to please type your questions and comments into the chat box. And we'll try our best to get to your question during our Q&A segment at the end of this talk. To start us off today, I'd like to turn it over to Dr. Model to provide an overview of diabetic kidney disease and discuss some of the highly effective treatments that can slow the progression of diabetic kidney disease.
Thanks so much, Tamara. So in an overview of these new medications, I just want to start out by saying we're living in a great period of time because we have new therapies for diabetes and chronic kidney disease, something that for many years we really were at a standstill. So if you can start the slide deck, please. These are my disclosures. Next slide. And here's an outline of what I'll be discussing over the next 15 or so minutes. I briefly want to touch on what is the connection between diabetes and chronic kidney disease, because a lot of people are still unaware that diabetes is even a risk factor for CKD. Also want to briefly go over what happens to people with diabetes and kidney disease, because generally it is a mostly silent disease, especially up until the very late stages of CKD. And then really what I want to dive into is, besides controlling blood sugar and blood pressure, as I think most people are aware they should be doing, what are these new treatments that have come across the board over the last several years? Next slide. So the connection between diabetes and CKD is really multifactorial. There's certainly elevated high blood pressure that's associated with diabetes, and of course, high blood sugar. And both of these entities lead to inflammation. But even aside from high blood pressure and high blood sugar, people with just diabetes alone can develop inflammation, which subsequently progresses to fibrosis. And so when we get any sort of injury to our skin or whatnot, when there's fibrosis, that's really a scar, and that's something that's not going to be reparable for the most part at this point, although we're even seeing that this may change as well. And these pathways then lead to decreased kidney function and albuminuria. And in fact, while 1 in 7 adults in the general population are at risk for kidney disease, it's really only 1 in 3 adults with diabetes who will be diagnosed with CKD. And when I say CKD, I'm referring not only to a reduced kidney function that we often refer to as an estimated glomerular filtration rate, or EGFR, of less than 60. And we can think of that somewhat as a percent kidney function, because in general, the upper range of normal is around 100. And so by the time we can actually diagnose somebody with a reduced GFR, they've already lost about 40% of the kidney function. And that's due to an insensitivity of our current approaches for diagnosis. Another approach is to look at the urine to see whether there's an elevation in protein. And the primary protein in our blood is albumin. So when it escapes into the urine, that's something that should not be happening. And it's telling us that there's damage to the filtration barrier of the kidneys. And we can measure this a number of different ways. We can do a urine dipstick, which is somewhat of a crude measure where we just look to see whether it's present or not present. Or we can measure over a 24-hour urine collection, or more frequently, what we do now is by getting a single random urine void and measuring both albumin and creatinine and taking the ratio. And the reason that we're doing the creatinine as well is basically to standardize so that we can account for, how dilute or concentrated the urine is. And if it's above 30 milligrams per gram, that's thought to be abnormal and putting people at higher risk of worsening albuminuria as well as low GFR. And so all people with diabetes should have an annual EGFR and UACR measured every year. Next slide. So then what happens once a person has been diagnosed? Well, sometimes people can remain very stable for years, even decades, but eventually there tends to be a gradual loss of kidney function. Oftentimes people will have worsening blood pressure control and will need multiple medications. And in cases where there's very elevated urine protein, people can develop swelling in the feet and the legs. But as I said before, for the most part, people feel okay. The most common complaints that I really get, and this really isn't until the GFR is below 30, but I hear a lot of people saying they're more fatigued than they used to be. Some people have a harder time sleeping. Muscle cramping is also prevalent. One of the things that I think a lot of the general population doesn't appreciate is the very, very high risk that chronic kidney disease poses for cardiovascular events and even death. And so what I mean by a cardiovascular event is a heart attack, a stroke, suffering peripheral artery disease, and congestive heart failure, where the heart's not able to pump the blood appropriately and people can accumulate fluid in the lungs and the legs. And then lastly, as kidney disease progresses over the long term, they eventually will need dialysis or kidney transplantation to stay alive. Next slide. So treatments for diabetic kidney disease for over 25 years now were predominantly comprised of ACE inhibitors and angiotensin receptor blockers. And these are blood pressure medicines that block a hormone that is generally upregulated in people with diabetes. And the renin-angiotensin system is multiple hormones, and the ACE inhibitors and the ARBs, and you can see the generic names for these, there's all sorts of them, inhibit this system. We also very recently came across mineralocorticoid receptor antagonists, and there are some older versions, but a newer brand called finerenone that is slightly different in molecular structure has come across and has been shown to significantly reduce the risk not only for progression of kidney disease towards dialysis and transplantation, but also to decrease the risk of cardiovascular events. You may actually have heard of this next one called sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitors. These were actually originally devised to treat diabetes. They actually make people urinate out blood glucose or sugar, but they also have actually been found to have an even stronger effect on protecting the kidney long term. And then lastly, our glucagon-like peptide 1 agonists, or GLP-1 agonists, and these medicines are also diabetes therapies, and they're very potent diabetes therapies. They also help with weight loss, which is often an issue in people with diabetes and even CKD without diabetes. And we know that they reduce proteinuria. They are currently in trials now to see if they can also slow the progression of kidney disease. But I'll be talking about these a little bit more in detail in a moment. Next slide. So just to go a little bit more into detail, so the renin-angiotensin system blockers, as I said, RAS is a hormone that's overactive in people with diabetes, especially once they develop kidney disease. And these hormones promote inflammation, fibrosis, or scarring, as I described before, as well as decreased blood flow to the kidney. And so ACE inhibitors are drugs like lisinopril, enalapril, ramipril, whereas angiotensin receptor blockers, which block a later hormone, include drugs such as losartan, valsartan, and olmesartan. And as I said, these are all blood pressure medicines, but they are also kidney protective medicines. And they are well known to reduce albuminuria, or protein leakage from the kidney, as well as the loss of kidney function over time. And we discovered that back in the very early 2000s. And, up until just a few years ago, these were the only drug classes that we had. One thing I do want to say is that while these are each helpful for people who have diabetes and kidney disease, we do not prescribe these two classes of medicines together. A person should really only be on one or the other because they are very overlapping in that same pathway that I described for the renin-angiotensin system. And when they're combined together, it can actually increase the risk for very high potassium levels and acute kidney injury. Next slide. Next is SGLT2 inhibitors, and there's been a lot of talk about these, so people may be familiar with them or have seen commercials for some of the types of medicines that fall into this class. And as I said, they decrease they increase the excretion of both sugar as well as salt in the urine. And this ultimately has an impact on the entire body to decrease inflammation. It improves heart function and the metabolic profile. So those are blood tests that measure our body's chemical balance. And they reduce the risk of worsening kidney function. They improve urine protein excretion. And they also prevent cardiovascular events, in particular heart failure, very effectively, as well as preventing death. And most experts agree that all brands are effective. And so whichever brand a person's health insurance covers is perfectly fine. Next slide. There are some side effects with SGLT2 inhibitors. The main side effect is really just an annoying effect of an increased risk for genital yeast infections, particularly in women, but men can also have the same side effect. And really what we advise is if somebody were to develop irritation in the groin region, to stop the drug, talk to their doctor, treat the yeast infection, and when it's gone, they can restart it. And if it happens over and over again, then it really calls for a discussion with one's doctor as to whether it's really the right medicine for them. But I found in my practice that it's very rare that this is a recurrent issue. People may have one yeast infection after starting it, and then I find that it really doesn't occur again. Another side effect that is not common but is very severe and so people should be aware of is an increased risk of diabetic ketoacidosis, or DKA. And this is much more common in people with type 1 diabetes, but can happen in people with type 2 diabetes. So if somebody has a risk of DKA, they really need to have a conversation with their doctor about whether this class of medicine is right for them. One of the things that we do tell people is to, when they're at increased risk for other reasons of developing DKA, and that's really when somebody is fasting, either because of a medical procedure upcoming or because they're ill, they should hold this drug and they can restart it once that condition subsides. And there's really no downside to this. A couple notes that people should take is that if you are on insulin or a sulfonylurea drug, possibly you may want to decrease these doses because it's possible that you'll have a reduction in your glucose levels with SGLT2 inhibitors, particularly if the kidney function is in the higher range. And we don't want people to develop hypoglycemia. The SGLT2 inhibitors in and of themselves do not cause hypoglycemia, but when taken in conjunction with insulin or sulfonylurea, these other drugs can increase that risk, and so they may need to be reduced. SGLT2 inhibitors are also diuretic drugs. As I said, they not only increase excretion of sugar, but also salt and water. So one may also want to consult their physician as to whether or not they need to decrease any currently taken diuretic medications. Next slide. And finally, GLP-1 agonists. The vast majority of these drugs are actually injectable subcutaneous medicines taken similarly to insulin. The ones that are most notable are the long-acting GLP-1 agonists that can be taken as infrequently as once a week. There is one oral version that is also available, however, it does not necessarily have as potent of an effect as do these long-acting versions. And so they, as I said earlier on, these are very good drugs at reducing glycemia. It can lower A1C by a whole percentage point, and also promotes weight loss via increasing satiety, so people just aren't hungry. It also increases the body's ability to use the sugar and improves vascular function or blood flow. So the heart function and the metabolic profile also improves. And so on this slide, I want to point out, I have a very large heart and a smaller kidney because this class of medications is really, really beneficial to people in terms of reducing the risk for cardiovascular events and death. They also, as I said, can lower proteinuria, and there is evidence that it can stabilize kidney function, especially in more advanced kidney disease. But there are ongoing studies to really ascertain exactly how beneficial they are in decreasing the risk for progression to needing dialysis or transplant. This is in distinction to the SGLT2 inhibitors that I just spoke of, which I had a picture of a big kidney because the kidney effects are enormous. And they're also beneficial to the heart, but not nearly as much as the GLP-1 agonists. And I will say that I use both classes of medicines in the vast majority of my patients with type 2 diabetes and kidney disease. Next slide. I spoke a bit about the longer acting versions that have the greatest benefit, and these are dulaglutide and semaglutide. There are some people who really can't tolerate these medicines because they have a lot of nausea and sometimes will end up having vomiting as well. Usually this improves in a couple weeks, but not everybody experiences this, and so it may just need to be discussed with one's doctor. Rarely people can develop pancreatitis. Otherwise, it is open for the vast majority of people other than those who have a family history of thyroid cancer. So that is another thing to discuss with one's physician. Next slide. So non-steroidal MRAs, these are mineralocorticoid receptor antagonists, and they are actually one of the hormones along the renin-angiotensin system pathway that I spoke about before. So aldosterone is the hormone which dramatically contributes to inflammation and particularly fibrosis. So blockers of this aldosterone function are helpful to restoring blood flow, heart function, increasing salt excretion as well. And one newer agent, which is the non-steroidal MRA, it's called finerenone. The brand name is Kerendia, has been shown in 2 very large trials of people with type 2 diabetes and kidney disease to reduce the loss of GFR and need for dialysis or transplant, heart failure, and even death. And so this finerenone or Kerendia is actually not the only MRA, but it is the only currently approved non-steroidal MRA. Other MRAs that are steroidal include spironolactone and eplerenone. These drugs have a higher risk of side effects that I'll talk about in just a minute. But they also have not been borne out in clinical trials to reduce the risk of progression to end-stage kidney disease, as has finerenone. Next slide. And so these are really well-tolerated medicines. Finerenone actually has a much lower risk of hyperkalemia than do the steroidal MRAs. And hyperkalemia is also a side effect of the ACE inhibitors and ARBs that most patients are taking as well. So it's important to really monitor the potassium to make sure that it doesn't go too terribly high. It is possible, if the potassium is going up, to either restrict one's potassium intake from their diet, or there are medicines to also lower the potassium level as well. And these are discussions that should happen with one's physician. And so the last point is, so these steroidal MRAs like spironolactone that are available are less expensive, but again, are not as rigorously tested as is finerenone. So if one's able to take the finerenone, I would definitely recommend that. Next slide. And that wraps it up.
Thank you so much, Dr. Model, for that presentation. And so for those of you who are just joining us, welcome to our session on the advancements in medical therapies for diabetic kidney disease. As a reminder, we will take questions at the end of our time today, but you don't have to wait until then to send in your questions. And I know a lot of people already have been. Please just go ahead and type your questions into the chat box, and we will try our best to get to your question during our Q&A session at the end of this talk. So just a quick question for you, Dr. Model. Can you share who would be the best candidates for these medications? And related with that, is there an eGFR cutoff?
Yeah, no, that's a great question. So it depends on the medication that we're talking about. So for SGLT2 inhibitors, they can be initiated starting at a GFR of at least 20, and they can be continued all the way down until somebody undergoes a transplant or initiates dialysis. There's no downside to that whatsoever. We typically do not recommend initiating them at an EGFR below 20 because we just don't have evidence of their benefit at that point. There's really no cutoff for albuminuria, how much protein a person has. It's been shown to benefit everybody regardless of their urine protein excretion. The finerenone really shouldn't be started below a GFR of 25. And for that particular drug, we only have sufficient evidence at this time for efficacy in people who have albuminuria. So a UACR, urine albumin creatinine ratio, greater than or equal to 30. And then lastly, for GLP-1 agonists, there's really no cut point for when it cannot be initiated. We even use them in our dialysis patients and transplant patients. But again, really, we prescribe those primarily for glycemic control, weight loss, and cardiovascular protection at this time.
Wonderful. Thank you so much. And now I'd like to transition over to Dr. Nicholas. So Dr. Nicholas, obviously there's a lot of data demonstrating the effectiveness of these medicines. And we're happy to have you here to share with us about some challenges of ensuring patients whose lives could be improved by these medications are actually able to get access to them. So I'll go ahead and turn it over to you, Dr. Nicholas.
Thank you, Tamara. Hello again, everyone. So Dr. Model did such an excellent job in describing some of the features and characteristics of individuals who may be in the advanced stages of chronic kidney disease. One of the things that we do want to take a look at, though, is the fact that these medications will be of little value to these individuals unless they are optimally used by those who would benefit most from them. So let's talk now about the underuse of these newer guideline-directed medical therapies. Next slide, please. These are my disclosures. Next slide, please. So over the next 15 minutes, I'd like to talk to you about why these guideline-directed medical therapies, or GDMTs, are needed in patients with diabetic kidney disease. We'll also discuss the underuse of these GDMTs and discuss some barriers to access to these medications. And then finally, I'll provide some ways or strategies to increase access to these guideline-directed medical therapies. Next slide, please. I think the first thing to talk about is why we want to avoid the health consequences of diabetic kidney disease. And as many of us may know, diabetic kidney disease is a significant public health issue with poor health outcomes, high mortality rate or death rate, and huge economic burdens. And when we look at the high rates of complications from diabetic kidney disease or worse health, we see that up to 10% of patients may progress to kidney failure. And in fact, many individuals may die early or prematurely from diabetic kidney disease, where their life expectancy might be shortened by as much as 16 years. And in fact, 90% of individuals may die from other causes even before reaching kidney failure. And over 50% of those who actually reach kidney failure may die from heart disease or cardiovascular disease, as Dr. Model had mentioned earlier. And you can imagine, to manage patients with these diseases and side effects and complications from diabetic kidney disease really would pose a significant economic burden. And so the United States has been costing us more than $80 billion per year to manage patients with kidney disease, accounting for almost 20% of the Medicare budget. Next slide, please. And while these numbers that I just presented to you may seem quite dire, the reason that I presented it to you is so that we can actually able to now refocus our attention to look at prescribing these medications in a more effective manner. My colleagues and I took a look at the new cases of diabetes, chronic kidney disease in patients with diabetes. And what we saw in a very large registry with data from 2015 to 2020 is that compared to individuals who are white, represented by the dashed line, it turns out that individuals who belong to several racial ethnic minority groups actually have higher rates of new cases of chronic kidney disease and diabetes. And these include individuals who are American Indian or are Alaska Native, individuals who are Black or African American, as well as individuals who are Hispanic or Latinx, and other individuals who are Native Hawaiian or other Pacific Islanders. And of course, we need to target everyone who may be eligible for these medications. But it turns out that these disparities that we show you here really remind us of the disparities that exist in similar individuals when it comes to incidence of diabetes and incidence of chronic kidney disease. So these individuals may actually have a even greater need for these medications. Next slide, please. So what are we asking clinicians to do? Well, according to the most recent Kidney Disease Improving Global Outcome Guidelines, patients with diabetes and CKD should be treated to reduce the risks of kidney disease getting worse, as well as for them developing cardiovascular disease. And these strategies should include not only lifestyle modifications that include the regular diet and regular exercise, as well as smoking cessation and weight management, but it should also include all the medications that we just talked about: SGLT2 inhibitors, renin-angiotensin system blockers, GLP-1 receptor agonists, as well as the non-steroidal mineralocorticoid receptor antagonists. Next slide, please. And it turns out that the use of these SGLT2 inhibitors may actually increase your kidney life by more than 15 years. As is shown in this slide, for someone similar to the individual in the upper right-hand corner of this slide, we see that for someone who is approximately age 63, they have slightly reduced kidney function, their GFR is 56, and they may even have some albuminuria. This individual may be representative of those who were included in clinical trials, particularly the Credence study, where they used an SGLT2 inhibitor called canagliflozin. For an individual who may be given a placebo or may be receiving usual care, not receiving the SGLT2 inhibitor, as you can see on this graph, they will experience a more rapid decline in their kidney function, represented by that lighter gray line, where it's much steeper decline in their kidney function. Compare that individual to someone who is using canagliflozin or an SGLT2 inhibitor, where their rate of decline of their kidney function is a lot less steep and results in an extension of their kidney life by over 15 years. So these medications indeed have significant benefit. Next slide, please. But unfortunately, many of these medications are used in clinical practice. Next slide, please. Next slide, please. And here we look at the use of these medications or the prescriptions of these medications, again, in our chronic kidney disease registry, where you see in the box, there's the use of these individuals or the prescriptions for these medications, particularly the angiotensin converting enzyme inhibitors and angiotensin receptor blockers, is actually less than 20% for those individuals who were all eligible for these medications. Compare their prescriptions to those prescriptions for non-steroidal anti-inflammatory drugs and proton pump inhibitors that can protect the stomach. The NSAIDs, as you know, are pain medications, and when they're used for a long time, in very high doses can actually have a negative impact on kidney function. We see here that prescriptions for these medications are actually higher than for medications for the RAS inhibitors that can be protective for kidney function in individuals who have kidney function between CKD stage 3A to CKD stage 5, just before they may require dialysis or kidney transplantation. Next slide, please. We looked more recently, again within our cohort of patients, at the persistence of prescribing of these guideline-directed medical therapies. And we found that at baseline, the prescriptions for the RAS inhibitors was actually greater than 70%. But when we extended that observation period to greater than 3 months, we saw that number of prescriptions declined or were reduced down to 40%. What you also see is that the prescriptions for SGLT2 inhibitors and GLP-1 agonists were fairly low, around 6% and 7%, primarily because these medications were just beginning to be used in these patients within this time frame. But what's important to see is even so, there's a decrease after about 3 months of observation. Next slide, please. And so we concluded that prescribing these guideline-directed medical therapies in patients with diabetes and CKD was essentially below what we would expect and continued to decrease very quickly over time, over a short period of time. It turns out at least 2 factors may have contributed to this. One was the lack of commercial health insurance, and the other was the type of healthcare system that the individual, where they received their care. Simply because in our study, individuals who received their care within our healthcare system at UCLA Health, compared to individuals within the registry who received their care at Providence Health, they received more, they did have more commercial health insurance, and they were also more likely to receive these guideline-directed therapies. And so we concluded that having insurance, and really having the right type of insurance and sufficient amount of insurance coverage and equitable access to care are important factors that may increase consistent and persistent use of guideline-directed medical therapies in patients with diabetes and chronic kidney disease. Next slide, please. These are not the only barriers to access to these guideline-directed medical therapies. Other barriers include the cost of these medications, as well as the complete lack of insurance, which of course will increase the out-of-pocket costs for care, as well as low or poor patient awareness, social determinants of health, and some of these factors may include poor or lower literacy, lower income levels, reduced housing, for example, reduced access to care. And in addition, provider education may also have an impact as a barrier to accessing guideline-directed medical therapies. Next slide, please. And here we see that prescriptions, the cost of prescriptions can greatly reduce access to guideline-directed medical therapies. In fact, over 75% of US adults think that the cost of prescription medications are unaffordable. And about 33% of US adults say they haven't taken their medications as prescribed due to the cost of their medication. In 2019, the United States spent over $1,000 per person on prescriptions compared to other similar countries. And when we look at the numbers, about 7% actually delayed their care due to cost. Another 6% did not get care because of cost. And another 9% either delayed their care or did not receive the care, again, due to the cost of their medication. So having health insurance and having adequate health insurance are important factors that can contribute to access to these guideline medical therapies. Next slide, please. And indeed, the lack of insurance can have a big impact, not only as a barrier to care, but also in delaying the diagnosis of kidney disease. And a delay in the diagnosis of kidney disease in of itself can contribute to increased morbidity and mortality and poor clinical outcomes overall. Next slide, please. And when we look at the social determinants of health, some of those factors such as access to healthcare and access to quality healthcare, as well as economic security and education and quality education, can also have an impact on the care of patients with chronic kidney disease. Next slide, please. So my colleagues and I made an attempt to see how we can have an impact to reduce access to care and access to these guideline-directed medical therapies. And we performed a pilot study, which we entitled Positive Kidney Health, in which we invited patients within UCLA Health who had diabetes and chronic kidney disease to engage with us using an interactive workbook that we created specifically for this project. Next slide, please. And with use of this interactive workbook, participants were able to keep track of their kidney health. They were able to better understand the medications that they were taking and to learn how to take care of other health problems that could potentially affect their kidney health. And in a patient-centered shared decision-making process, they could set goals that they themselves would be able to achieve. And finally, they can create an action plan to improve their health. Next slide, please. What we found is that at the end of the study in panel A, that there was a higher number of individuals who had greater confidence in understanding their kidney numbers that Dr. Model talked about, the EGFR and the UACR, urine albumin to creatinine ratio. In addition, as you see in panel B, more individuals at the end of the study had a correct response to the question, what does your EGFR stand for? And then finally, in panel C at the bottom, we see that there were a higher number of individuals in the blue hatched bars that had a much better perspective and felt that the information they were provided was more helpful compared to individuals, fewer individuals who felt that the information that they were provided was either scary or deterred them from gaining and empowering themselves to take care of their CKD health. Next slide, please. And so with that, I'd like to leave you with some strategies to improve access and the use of guideline-directed medical therapies. On the patient side, patients can become more aware of the risk factors for CKD and CKD progression. They can ask to get tested for diabetes and for chronic kidney disease. They can ask their doctor if they are eligible or if these guideline-directed medical therapies are right for them. They can also ask their doctor to switch their medications to a generic brand, a generic, I should say, medication instead of the brand name medications, which tend to cost more money wherever that becomes possible. And on the provider side, providers can more efficiently identify patients who have risk factors for chronic kidney disease earlier. They can also identify patients with high risk for CKD progression and also initiate and maintain these guideline-directed medical therapies. As you can see, it requires that these patients take these medications for a really long time in order to get the maximum benefit. Also, providers can use a patient-centered approach to interact with their patients and to increase the patient's input into their own diabetic kidney disease care strategies. And finally, providers can increase timely referral to a nephrology expert. And so with that, I'd like to say thank you. Next slide, please. And we could move on to questions. Absolutely.
Wonderful. Thank you. Thank you so much, Dr. Nicholas. That was very informative. And now I want to turn to our final speaker, Dr. Patrick G. he is someone who has lived with diabetic kidney disease. And so, Dr. G, I'm wondering if you can share with us just a little about your experience with diabetic kidney disease and these therapies. And in particular, what advice do you have for someone who is considering these therapies as an option?
All right. So just to give you a little bit of background, in 2003, um, I was diagnosed with type 2 diabetes. I was at work one day just feeling very sluggish, lethargic. I went to the nurse's station. She asked me, have I ever had my glucose checked? And I didn't know what she was talking about. And when she checked my glucose level at that particular time was 758. So immediately I was sent to the emergency room where they did blood work and told me that my A1C at that time was 11.7. So I was recommended to an endocrinologist who ended up becoming my primary care physician. And she treated me for diabetes up until 2013. During that particular time, she put me on two different types of insulin as well as metformin. So April of 2013, just as a routine visit, um, I thought everything was fine. As I'm getting ready to go out of the door to exit the building, my endocrinologist was like, "Oh, Patrick, I forgot to tell you that you are at stage 3B of end stage kidney disease, and that your kidney function is between 30 to 35%." Um, I was lost. I was confused. I really didn't know at the time actually what my kidneys did. I was mad because the question I asked was, well, why didn't you tell me at 75% or 50%? But I never got a response to that. The only thing I was told was that I was going to be referred to a nephrologist. So a couple of weeks went by. I was referred to a nephrologist. The nephrologist point blank told me, "You're going to eventually go on dialysis, but what we need you to do to slow down the progression um, of your declining kidneys, we need you to abstain from dairy products, nuts, and chocolate." So some months went by, and during the time of my waiting to begin dialysis, I had picked up a total of like 150 pounds of fluid. So I never forget November 2019, I mean, excuse me, 2017. I went to my nephrologist's office. Uh, I think I was probably close to about 397 pounds. Couldn't
Hmm.
sleep, laying flat because it felt like I was choking. So I had to sleep sitting up in the chair. Um, in that visit, the only thing I could wear was a pair of black sweatpants, white socks, and white t-shirt and flip flop because I had literally outgrown all of my clothes. So when we got in, I'm sitting there hyperventilating because I can't talk. And my wife asked the nephrologist, "When are you going to start my husband on dialysis?" So the modality that I chose was peritoneal dialysis. He scheduled the surgery for the peritoneal catheter to be placed. And about a couple of weeks later, December the 1st, 2013, is when I began my first exchange of peritoneal dialysis. So lo and behold, I'm doing dialysis and my glucose level is all over the place because I'm using dialysate, and it's really not helping me to be able to manage my diabetes. So uh, April the 21st, 2017 is when I get the call to get a kidney. I get my transplant that day, but when I wake up, the kidney did not wake up. I was dealing with delayed graft function. So they told me that I needed to do hemodialysis 24 hours a day, every other day. So 5 days after my transplant, I had a blood clot in my neck, and they told me that I needed another surgery. 3 days after the blood clot surgery, I was hemorrhaging. I needed another surgery. 17 days later, after hemorrhaging, um, they performed a procedure known as a laparoscopic peritoneum window, so they could create access inside of me for me to be able to drain, yet my kidney still was not functioning. So after a total of 4 surgeries, 33 days in the hospital, 6 days in a rehabilitation center, I finally came home. Mind you, 2.5 years prior to my transplant, I wasn't able to urinate. I was in complete stage 5. So on the 47th day from the transplant is when my kidney kicked in and that first drop of urine hit the water. And it was almost like a revelation of some of the things that we really take for granted. And it just, uh, it was just like a switch clicked in my mind. I really need to do something to help the underserved community. So lo and behold, my kidney started to function better. And one of my transplant nurses said, "Well, Mr. G, you're doing good, but you are still overweight." And she recommended for me to go to a weight loss clinic within the hospital. So going there, I learned a little bit about nutrition, especially dealing with type 2 diabetes. So at this particular time, I chose to do the ketogenic diet. And in doing so, they took me off of all of my insulin. And during that particular time, I lost between 75 to 85 pounds. And September of 2019, while being a member of the Kidney Health Initiative Patient Family Partnership Council, the chair at that particular time told me that the ASN Diabetes Kidney Disease Collaborative Task Force was looking for a patient representative. Well, I quickly applied and I was invited to be a part of that group. Um, since being a part of that group, it was an honor and a pleasure to be with these experts that kind of made a place for me at the table. Everything that they developed, that they talked about, that they wrote about was centered on myself and patients currently living with diabetic kidney disease. It was one of the greatest honors. And I had the opportunity to sit firsthand and listen to these experts talk about these different new therapies that I had never heard before. And I believe in January of 2020, when we had our very first in-person um, workshop, I took the information and I went back to my weight loss doctor and I told her about SGLT2s and GLP-1s. And we really had an in-depth conversation. So February of 2020 is when my doctor recommended for me to go on a GLP-1 agonist. And ever since then, um, my A1C has averaged anywhere between a 5.3 and a 5.9. So I was very grateful because of that, because some of the complications dealing with diabetic kidney disease, I was already dealing with diabetic retinopathy and diabetic uh, neuropathy, and all of these different challenges. So now that my diabetes is well managed, now that my kidney function is well managed, it just gives me the leverage to be able to go into underserved communities, whether rural or urban, and to be able to share not only my story, but these new therapies and also encourage um, other patients living with type 2 diabetes, dealing with chronic kidney disease, and dealing with cardiovascular disease to have a conversation with their physician and talk about these particular therapies, show them the data behind this, also to encourage them if they're interested in participating in clinical trials to do so and just spread the word in the communities that these things are literally life savers. So thank you very much for allowing me to share my story.
Thank you very much, Dr. G. I really appreciate that. And thank you to all of our panelists We are at this moment running a little short on time. We have about 5 minutes left. So I did want to get to one question that's been coming up in the comments, which has to do with the costs. So for individuals in our audience who may experience barriers around accessing these medications due to the costs, can you share about future work that's occurring around reducing some of these barriers? And whoever would like to take that can go for it.
I can take a quick stab at that, and
Okay.
then Amy. So I personally, although I can't specifically decrease the costs as they are right now, I think one of the things that we can do, my belief is knowledge is power, and from the pilot study that I showed, we hope that, from this publication, that providers out there, as well as patients, can really appreciate that by going through this patient-centered, patient-focused strategy, we can really empower patients to take care of themselves, but also to connect physicians with the patients so that they can really identify the individuals who are most in need of these medications and to take an active part in making sure that they do obtain the medications that they so desperately need to reduce their poor kidney outcomes. One of the things that we're doing right now is I co-lead a study that's NIH supported that actually uses artificial intelligence to identify targeted risk factors for individuals who have a more rapid decline in kidney function, particularly in racial and ethnic minority groups. And we hope that we'll publish this later this year so I can provide guidelines for healthcare providers out there to identify those individuals who have the specific profile and risk factors for rapid decline in kidney function so they can be targeted for these medications. Amy, do you want to add anything to that?
Suggestions that most people may be aware of, but first of all, the same drug can vary drastically between pharmacies. So going to GoodRx is a great place to look for the lowest cost. For people who have private insurance, the copays can be huge. However, most of these drugs still have manufacturer assistance programs. So if you even just do a Google search of the drug and punch in manufacturer assistance, you can usually online do a quick assessment to see if you're eligible, and that can drastically reduce the copay down to anywhere from $5 to $50, depending on your insurance. In terms of people who don't have any insurance, there is also a manufacturer assistance that can sometimes help with that. It's also helpful to know, I don't think most people appreciate that if you go to a safety net hospital in your area, most of these hospitals will have some sort of a pharmacy assistance program, and at least SGLT2s and GLP1s are usually on formulary there and can oftentimes be obtained at a low cost. The good news for SGLT2 inhibitors is that they're coming off patent in the next couple of years. So we'll start to see, generic level costs, which will, give us a lot of financial relief.
Wonderful. Thank you so much. And I'd really love to just thank all three of our panelists for an extremely informative and enlightening discussion today. And I want to thank our audience for participating, for all of the questions that you put in the chat. I'm sorry that there was so much information. We did not have time to get to all of the questions. But we have a lot of resources on our website and on our Facebook page where you can learn more about these topics. So I'd encourage you to do that. And up next, we have Melissa Baker, a dialysis patient story, which will begin at 5:05 Eastern, followed by the Ask a Nephrologist session at 5:30 p.m. Eastern. And I know that a lot of people are eagerly awaiting the Ask a Nephrologist session, so I'd encourage everybody to participate in that. Once we conclude this session, you will see a poll for a quick survey pop up. So please take a minute to fill it out and tell us how we did. Your feedback will be very helpful as we plan future sessions. And finally, I'd just like to thank everyone and wish you a wonderful rest of your day. Thank you.